How do you measure success?
Really just measuring engagement. That's how you measure trust building, the opportunity long-term to impact clinical outcomes. How long does it take for us to enroll someone into the program and build trust? How often are they talking to us?
Hey, it's Adam Silverman, host of, there we go. Hey, it's Adam Silverman, the host of Syllable's new podcast, Solve. And we are still here at Health in Las Vegas 2022. And right now, I am so thrilled to have a conversation with Cassie Choi. That's Cassie Choi RN.
Yes.
I have to make sure that everybody gets their occupational props. We are thrilled to have you. You are a co-founder of Pair Team, which, as I just learned, is PAIR Team, not Apple and Pear Team.
Exactly. Thank you so much for having me. Happy to be here.
Absolutely. We're thrilled to have you too. So tell me a little bit about Pair Team. What are you trying to solve? What's the problem that you're addressing?
Yeah, so Pair Team finds, engages, and cares for our most highest risk, highest needs Medicaid individuals in our communities. And so what we are is a wraparound virtual and hybrid model care team to support our safety net clinics to provide the extensive care that is required for the folks who are the highest cost of care to our Medicaid system.
So let me get this right. You're an entrepreneur. You're a co-founder of a startup, which is dependent upon revenue and growth and things like that. And you're working with the Medicaid population, which isn't really known to be particularly flush with funds.
No.
So how's this all work?
Yeah, so this was actually a really hard thing for me as a clinician, was to become like an entrepreneur that makes money because a lot of the things that I was trying to build are things that I just deeply believe should be true of healthcare and that patients shouldn't have to pay for it. And so over the 4 years, we've really had this journey of figuring out how do we create a care model that builds trust in the healthcare system, engages folks in their care plan, improves clinical outcomes, and reduces total cost of care and get paid for it. But luckily, California, of course, just did a very big investment in Medicaid expansion. It's called CalAIM. There's over $8 billion allocated to the care of Medicaid individuals with a goal of reducing total cost of care. And what's really interesting about CalAIM is that they've really put a focus on health equity and paying for things that really help those who have those social barriers. And so we're a part of the Enhanced Care Management Program, where there's PMPM, so per member per month dollars, for enrolling and caring for folks that meet certain eligibility criteria, such as homeless and severe mental illness, high utilizers, and that those groups expand significantly. And so what that allows us to do is really build a chassis for developing the care model and the tooling required to care for the highest risk folks, and then bring them into a risk-based model.
So if I dumb it down, it's cheaper to pay for a ride to the doctor's office than to pay for the hospitalization for the care that wasn't delivered.
Yeah, there's an amazing book called God's Hotel by Dr. Elizabeth Sweet. She worked at Laguna Honda, which is an amazing hospital in San Francisco, caring for high-risk individuals. And there's an amazing story where she said that she would care for this individual who was basically at Laguna Honda over and over again for long-term care, and all he needed was a pair of sneakers to leave. And so she just brought in a pair of sneakers and he was able to go back into the community and really thrive. And if you think about the cost of that intervention compared to the cost of just keeping him in the hospital, these examples happen all the time.
Right. So in contrast to Medicare, which is a federal program governed by, for the most part, a single set of rules, Medicaid is, although it's funded partially by the federal government, it's a state-by-state program. So as you think about the work that you're doing and expanding beyond, how does that sort of quilted approach to Medicaid coverage impact what you're thinking about from a strategy standpoint?
Yeah, the state-by-state nature of Medicaid is very complex, but I love a good problem. And so really, if you think about it, we all need to think about total cost of care reduction, right? And MA has shown that a lot of folks are invested in different sorts of models, value-based models for that. And now there's a lot of attention in the Medicaid space around how do you do this effectively? And so again, we're building on the chassis of enhanced care management, which other states have versions of this. It's called health homes. And they're really looking to California to figure out how does this work? What are the good interventions, the costs, the structures? But overall, every state is interested in reducing total cost of care. and moving risk down to the provider level where they're making the decisions that can impact total cost of care. And so we believe truly that this trend will span across multiple states. Some will lag behind others, but it's just the way that the future has to exist. And I'm excited that CMS is really placing a focus on value-based care and health equity in the Medicaid space.
So tell me a little bit more, go a little bit deeper into the solution. What is it that you're actually doing?
Yeah, so imagine concierge convenient care meets the Medicaid population. And what that really looks like is we have community health workers on the ground around our partner clinics to help find, engage, and care for those high-risk individuals who often have significant barriers to coming into the clinic. And so our community health workers will meet folks at our partner community-based organizations. So homeless shelters, food pantries, hospitals, like where are these folks living and receiving care or lack of care, and meeting them in the community. But our CHWs will not scale as fast as a virtual team. That makes it really convenient to access us via text message and phone calls. We don't create barriers with video visits and apps or anything like that. And our care team consists of virtual community health workers as a lead care manager, as your main point of contact to really guide you through all of the challenges of life, and around them a multidisciplinary team. So we have nurse case management to help navigate complex clinical conditions and health education and really transitions of care and capturing them as soon as they leave the emergency room. We have mental health on our team to really help do interventions and assessments and bridge to the community providers, where in Medicaid there is a significant 3 to 6 month wait to get even evaluated by a mental health provider. And so our mental health providers can do that real-time telemedicine mental health support. And then we also have social work to really, bring people into the community to have their needs met, and really make sure that when we refer someone to an agency, that agency can adequately provide that care. I think as SDOH has become a more hot topic, as it should, clinicians are not well equipped to understand how to refer folks out for the things that they're finding. And then last, we also have nurse practitioners. As a nurse myself, I very much believe, no offense, in the nurse practitioner model.
None taken.
And so we have nurse practitioners on our team to do virtual urgent care access and, really take over those complex care plans that our safety net providers have a difficult time having time to thoroughly build and follow up on.
So when we started this conversation, I thought what you were going to be telling me about was a technology platform that you were going to partner with providers to help take care of this very difficult patient population. It sounds like you're also a provider too.
Yes, so we are definitely a provider, but we are a tech company as well. And so we really use our platform that we've built in-house to really figure out how to adequately engage folks and build trust. If you can't impact outcomes or total cost of care if you don't have the core unit of trust with an individual. So our platform has, communications and capturing notions of family members and support systems and agencies. And in the center of it really is a shared care plan, which I think a lot of EMRs just don't have that notion. And it's
Right.
a patient-centered care plan. So what is the problem that they're facing? What is their goal? And what are the interventions that can be taken? And based out of those interventions, we have automated workflows to support the administrative burdens that get in the way of that trust building. Also, from the data component, which data is huge in healthcare, right? We're able to integrate data from the EMR and health plan claims data to really understand who should be engaged, what eligibility criteria may they have, and really bring them into care for targeted interventions, targeted engagement, and targeted interventions that are more cost effective.
So I want to talk a minute about risk stratification.
Mm-hmm.
So I was medical director for a waiver, Medicaid waiver program in Massachusetts several years ago.
Yep.
And we put together a lot of the services that you just described. And, the foundation of population health is that 5% of the population is responsible for 50% of the spend.
Exactly.
Everybody in Medicaid falls into that 5%. The struggle that we had is, how do you find the impactable 5% or the 2%, whatever the percentage is? Because we just didn't have the fidelity in either the screening tools or even the claims data, which was frequently months beyond.
Yeah.
And quite honestly, some patients' behavioral, physical, and socioeconomic problems were so intractable that you could throw plenty of resources at them, but you weren't necessarily going to move the needle. So how do you do your risk stratification so that you can deploy your resources in the most appropriate way?
Yeah, I think as an industry, as we get access to more and more data, our ability as an industry to better risk stratify will just get better. And so I think one of the key things right now is an engaged person, right? If someone is engaged in care, right, you are able to better invest in resources, right? Rather than just giving someone a taxi voucher and then they never go or something like that, or investing in all these different resources for somebody who's just not engaged, right? And then thoroughly evaluating the folks who they're just going to cost a lot of money, right? Like their clinical conditions are just past a point where you really, the cost reduction measures are just not that meaningful versus reallocating those resources to someone where, you can make a difference, whether it be, finding a bed for them through partnerships with CBOs or enrolling them into a chronic care management program that is tied to the social interventions that you're doing at the same time. But again, it comes back to the core component of like, how engaged is this person?
Do you have, are you maintaining ambulatory offices and managing real estate and things like that, or is it all virtual and home-based?
So 95% of what we do is virtual. And we are a wrapper of our safety net primary care clinics. And that's where the in-person care comes into play. You really, I love telemedicine, but the idea that we can do everything in telemedicine is just not true, especially in the Medicaid population. Some things need to be done in person. And that's where we rely on our partner safety net clinics. We actually are white labeled. Our patients that we care for think that we are a special team at the clinic that they always go to, or they may not even know. A lot of these folks are just unengaged in care. But we tie it back to a physical location that they can walk by, drive by, take the bus back to, and rely on them and that partnership to provide the in-person care assets. And so, our documentation of care provided goes back into their EMR. So it's really a seamless experience for the patients. We're just providing a more convenient way to access that care for those who really need that.
So when I was on the provider side, there was a frequent refrain from administrators that when you're dealing with the Medicaid population, if you're talking about technology, forget about it. You're not going to be able to get anybody. You're not going to be able to do a telehealth visit because they don't have a computer or they don't have a cell phone. So I know the truth behind it, but can you tell the listeners, so what's the truth behind the Medicaid population and the utilization of technology?
Yeah. So first, COVID has been amazing in that we've been able to really double down on what we knew was true in telehealth, but we needed some sort of forcing function to gather the data and really see what is true. And so Medicare lifting restrictions around video visits and things like that really allow for a lot more expanded possibility to reach folks on the other side of the digital divide. There will be folks who will always be on the far end of that digital divide where technology doesn't make sense and it's just too hard, right? But there's a huge group of folks on just the other side of that digital divide where you just need to make the right adjustments for them to access those benefits. So whether it be text-based only because folks don't have enough minutes on their phone, or not doing a video visit because, even I have a hard time figuring out which app, which link, all of that sort of stuff, making it just more accessible via a phone call. And the last is an app and a patient portal, right? I don't know how many times people are going to their patient portal, but it also becomes cumbersome for providers to manage messages and things like that. So if you just let people reach us the same way that they would reach their sister or a friend or their mom, right? It reduces that barrier and really helping people, learn how to delete their voicemails so that you can leave them another voicemail and save your phone number, walking them through that. Seems outside of healthcare, but really makes such a difference with folks. And I think we can't take this streamlined approach that if you don't understand all the technical components of the things that we're, building in health innovation, then it's a lost cause in the Medicaid population.
Right.
And we're seeing the effects of that.
How do you measure success?
So long-term reduction in total cost of care, right?
That takes a while, though.
It just takes such a long time, though. And so right now where we're at, really just measuring engagement, right? That's how you measure trust building, the opportunity long-term to impact clinical outcomes. And so we measure engagement, how long does it take for us to enroll someone into the program and build trust? How often are they talking to us? We see that in our enrolled panel of folks that we're providing complex care management to, about 3 touch points every single month. Some of them are proactive by patients. They'll even tell us that they changed their phone number
Wow.
and reach out to us again.
Yeah.
Or it's our care team reaching out to them to check in or move the care plan along, but they're fully engaged. The other piece of it is like, how much of the population can we actually reach and impact? And so the average safety net primary care provider can reach about 10% of this like very high cost population. And those are the folks who are already coming in all the time, right?
Yeah.
Those high utilizers, like those are a different population. What we're seeing is over a 6x impact to those populations and reach at engagement rates over 60%, and it still climbs. The other piece of it is data. Health plans and providers don't know who these folks are. To your point, like the claims data is so lagged, but also a lot of these folks have just fallen out of care that results in this data. And so how can we find these individuals in other ways? So again, coming back to those CBO partnerships, enrolling them into Medicaid to help them get access to the care that will really improve their quality of life. Finding different claims algorithms to really identify these individuals rather than just like an ICD-10 code, a Z code for SDOH, right? There are other factors that you can use to predict total cost of care.
What keeps you up at night? And if you sleep great, that's awesome.
I don't. I actually fall asleep and I just think through all the things. I'm a very vivid dreamer, and I will relive conversations and opportunities and wake up and just like write them all down. I think what like I frequently think about is how to scale this in a way that my team can be a part of, right? It means so much to me that every person that's joined Pair Team has chosen this as the thing that they do during the day. It is such meaningful work to me personally, and I think to a lot of folks, but it's also incredibly taxing. Like the social things that we're facing and the barriers in the healthcare system and social system they're massive. And it's really easy to burn out when you're in this work. And so, we're growing like crazy. There's such a need for this. We've found that revenue, the go-to-market. And so how can I make sure that my team can keep up with that pace and just the day-to-day like realities of the people that we care for?
And how do you balance mission and the entrepreneurial spirit that you represent?
Yeah. Like I said, that was hard.
Yeah.
Like the clinician in me who just like believed that it's like the obvious stuff should be true. It was really hard, but I think reconciling with the idea that, what drives me is impact. And I think that's how I moved from like the bedside to like being a part of something that was being built, and then building something myself that I want to see impact with. That impact scales with the business side of it, right? The more revenue we have, it gives us the right to enter other communities and find other ways to impact people. And so that's what I think about, is like tying the business KPIs to the things that are meaningful to me in terms of impact.
Do you find that in your role, there are specific obstacles on a daily or weekly basis that you're always coming back to trying to knock down, but keep resurfacing?
Yeah. I mean, I'm an operations person. Sure, there's like how do you make the contracting process happen faster with plans and go door to door with like these small clinics. But we can solve that, right? I think what's hard is like on the operations side, a lot of the folks that are joining us on the ops side are very mission driven. They come from the communities that we serve. But the pace of change and innovation and iteration at a startup can be a lot to take on. And so how do you scalably create like processes for change and documentation and resourcing for those individuals? Again, it comes back to like, how do you take care of the team when everything that we do depends on execution?
So when I practiced in Connecticut, for the safety net population, there were a number of participants in the care delivery. I won't say that we were really competitors, because we weren't organized enough to be competitors, and at the time people didn't think about competing for the Medicaid population. But there were the hospital-based clinics, there were the federally qualified health centers, there were the look-alike health centers, and then there over time became sort of other entrepreneurs that came in with other models. Do you find is there something similar in California where you're not necessarily competing with other providers, but where it may be a confusing landscape?
Yeah, I think, the safety net providers are very lagged on value-based care concepts and alternate payment models, APMs, right? They're holding on to their $14 PMPM capitation for primary care, and they still have the operations that reflects a fee-for-service model. And I don't see them as competition, right? There are large FQHC groups that are a lot more sophisticated who've built out their own care management programs and all of that. That's fantastic. We're here to support the rest of them that cannot do that don't have the revenue to get ahead of that, right? And so in terms of competition, if we're talking about taking risk long term, there's a lot of different companies that are taking their different approach and thesis to how to do that effectively. I mean, the Medicaid space is very like white right now, all things considered, compared to like Medicare Advantage innovation. But I think there's a lot of point solutions, right? There's like community health workers, there's mental health, and from a lot of things aren't going to happen if the health plans aren't bought in, right? And health plans can't stitch together each of these independent solutions. Clinics at their scale can't do this over and over and over again. What we're doing is not net new, right? Like, we know how to reduce total cost of care. It's just the ability to do these things consistently on a basis of an engaged population. And so stitching together a unified clinical and social network, bringing clinics into this to help them realize the potential of value-based contracts, it's a slow process, but that's more of our approach. And I think if you worry about competition, you're gonna die before that anyway. And so just focusing on what you're doing it really, really well. There's a lot of space in healthcare to solve these challenges.
So you guys won an award. Tell me what the award is.
Thank you. We were recognized as UCSF's Rising Star for the new telehealth innovation category.
Congratulations.
Thank
That's
you so
terrific.
much. Thank you.
So now you're getting some press. So inevitably somebody's going to find you and they're going to say, Cassie, love what you're doing. How do I be like you? You know, but it could be a young nurse in nursing school. It could be somebody coming just out of college saying, you know, I really love what you're doing in the Medicaid space. I love the emphasis on mission, but I don't know how to get involved. What do you recommend?
Yeah. So one of my other huge passions, Pair Team's my baby, but my other huge passion is bringing more clinicians into the innovation space, but especially nurses. I think nurses have very much been overlooked in digital health innovation as in their way to contribute towards solving this huge problem. Plus, with the mass exodus of nurses leaving the bedside, I mean, we graduate 150,000 nurses a year in the United States, and within 2 years, those new grads will be gone. We are facing an existential nursing and healthcare crisis. And so how do you take all of their learnings, their knowledge base, especially their operational knowledge, and bring it to solving these challenges? And so I always encourage nurses to really think about the skill sets that they're building in whatever environment that they're in. I mean, the core skill sets of nurses, right, are assessments and care planning and interventions and relationship building and education. That's all entrepreneurial skill sets called something else, right? Evaluating a problem, product development, solution fit, pitching, and developing relationships with folks. And so these skill sets are so transferable, but you have to be very cognizant of what those are and be willing to just stretch yourself and feel uncomfortable. And I think a lot of nurses are used to that as new nurses, everything is scary. And I remember taking my first blood pressure and being I can't do this, it's terrible. And then you do a blood pressure in your sleep after a while. And I think just willing to be uncomfortable can lead to amazing things. And so the path to be an entrepreneur for me was not immediate. I really had to get my bearings around me. And so I joined a startup on the operations side, contributing my clinical knowledge base and reflections around operational capabilities. And while I was there, I really took the opportunity to learn from everyone that was around me that was in a new space for me. So working really closely with engineering and product and strategy and sales to just learn from them and try to apply those different skill sets to what I might want to do next. And I did that a couple of times before really being the only way I'm going to feel uncomfortable and learn more is if I become an entrepreneur myself. And if you're not from healthcare but are really drawn to healthcare, I think it's really important to understand the problem set. And healthcare is so big, but really zeroing in on what part of the healthcare landscape do you want to solve? What do you need to know about it? And then the biggest thing is networking. Like, there are so many knowledgeable people in the healthcare landscape who know different segments of so many different things. And so just getting out there and networking and learning from folks and being willing to ask those questions in order to learn.
That's not an innate skill, though, is it?
No.
I mean, at least nobody ever, in my medical school training, nobody told me about networking. I mean,
No.
you just...
Me neither.
And you have to watch other people do it.
Yeah.
And there's some people that are just really skilled at it,
Yeah.
that it's impressive.
I mean, I'm an introvert, so like
Yeah,
networking
likewise.
at the conference here,
Yeah.
like I'm that person that doesn't want to jump into a conversation that's already happening. But I mean, you can even do it through LinkedIn. I have a lot of folks who reach out to me and be like, hey, I want to learn about this. Can we find some time? And paying it back to folks that you network with is, you just have to do it, honestly.
I agree. Cassie, I am thrilled for you and your co-founder. I think what you guys are doing is amazing. I hope we can come back in a year and talk again and see what kind of progress you guys have made.
Thanks so much for having me. I
Cassie
really
Choi,
appreciate it.
co-founder and COO of Pear Team. Thanks so much.
Thanks for having me.
You bet. How'd we do? Gucci.
Gucci, I like that. Thanks. That was easy.